A 8-month-old baby suspected CP angle tumor needs MRI, but patient has history of URI since 3 days. Discuss anesthetic management. My anesthesia concerns are general pediatric concerns, separation anxiety, risk of hypothermia, difficult IV access, and difficult airway. And non-operating room anesthesia is my concern. And recent URI, it increases airway hyperreactivity, increased secretions and decrease airway caliber, and bronchospasm, laryngospasm, and breath holding, hypoxia, atelectasis. On procedure related, it is a time-sensitive surgery. Airway hyperreactivity is common after an upper respiratory tract infections up to 6 to 8 weeks. It causes are infectious and non-infectious. Infectious is most common, that is rhinovirus, streptococcal pneumonia, and influenza and croup. Non-infectious causes asthma and foreign body aspiration. Symptoms and signs, there may be clear rhinuria, fever, lethargy, and irritable. Risk factors for peri-op adverse respiratory events are coughing, breath holding, laryngospasm, bronchospasm, post-extubation stridor, and airway desaturation. In children with active and recent URI, within 2 to 4 weeks have significantly more episodes of breath holding and oxygen desaturation. Pathophysiology of airway hyperreactivity, it's mainly due to release of chemical mediators and neurologic reflexes. And secondary to infection and inflammatory mediators like bradykinin, prostaglandins, interleukins, histamines, and stimulation of M2 receptors also leads to inhibit the acetylcholine release. And tissue factor, neuropeptides, and tachykinins, that is the main causes of airway hyperreactivity. Recommendations: child with URTI, if elective surgery, we can postpone procedure for 4 to 6 weeks. If it is emergency surgery, we have to be very conscious. And symptoms: mild, moderate, severe. If it is mild, like clear runny nose, sore throat, and dry cough, we can go for procedure. If it is moderate or severe symptoms, individualized risk or benefit ratio. We can postpone the surgery if the age less than 1 year. Yeah, if any airway surgery, immunocompromised, and fever more than 30 fever, and ET tube requirement. If in favor to proceed, a minor surgery and emergency surgery, and use TIVAP wherever is possible. Coming to NORA, non-operating room anesthesia outside the operating room. It can be demanding, and possible challenges must be anticipated and prepared for it. If adequate preparation is not ensured, critical incidents may occur in remote locations. Adequate skills in airway management and the ability to intervene when they are required. It's a prerequisite for anesthesia provider delivering the NORA system. The attending anesthesia provider should have good understanding of the procedure. We have to check the equipment and monitors, oxygen and backups, and suction machines. Anesthesia machines should check, and difficult airway cords should be ready and kept. Crash cords should be kept ready, and drugs like basic drugs, emergency drugs, and defibrillators should be kept ready. Providing anesthesia in remote setting may be associated with higher incidence of risk, like due to lack of vigilance, no backup plans, and inadequate pre-procedural evaluation, multiple medications, inappropriate choice of anesthetic technique, and use of non-anesthetic staff. In my procedure, patient posted for MRI, it is a time-sensitive surgery. We can go for MRI, sir, with conscious total intravenous anesthesia, sir. Preoperative assessment, anesthesia goals are minimize secretions, minimize airway manipulation, choice of airway device like face mask, then LMA. Anesthetic agent, prefer IV induction agent like propofol, avoid and inhalation isoflurane or sevoflurane, avoid desflurane, smooth induction and awakening. Lab test, CBC, complete blood count, chest X-ray if required. Pre-op assessment, birth history, thorough history, weight should be noted, nature of respiratory tract infection, associated fever or not, nature of nasal discharge, auscultation to rule out any wheeze, vitals and temperature should be recorded, adequate NPO, follow NPO guidelines, and continue corticosteroids and bronchodilators. Monitoring, standard monitoring, ASA monitoring, IV line is secured with inhalational with sevoflurane. Child should be well hydrated and humidified to clear secretions. Use face mask and total intravenous anesthesia. Pre-medicated with IV glycopyrrolate and an anxiolysis agent IV midazolam 0.05 mg per kg and IV fentanyl 0.5 to 1 mics per kg. IV lignocaine 1.5 mg per kg. It induced with ketofol, ketamine 0.2 to 0.5 mg per kg IV plus propofol 1 to 2 mg per kg and maintenance with propofol infusion or intermittent bolus, suctioning in deeper planes if required. In post-procedure, baby should monitor recovery room at least 1 hour with standard monitoring, paracetamol supported if required, strict monitoring for apnea and continued nebulization, sir. Thank you, sir.
Can you read out the case history again?
Yes, sir. 8-month-old baby suspected CP angle tumor needs MRI. But patient has history of URI since 3 days. Discuss anesthetic management.
So is MRI a surgical procedure?
No, sir. Non-operating.
It's an investigation done
Okay.
in a non-operating setting. Okay.
Okay,
of course, your discussion of the URI patient coming for surgery, major, minor, whether requiring intubation or not, are all good for knowledge to be spread or given to the juniors or youngsters who are just entered the specialty.
Yes, sir.
But in exam, you must stick to what is the case scenario given to you.
Okay,
It
sir.
is only MRI procedure. What is the most important requirement of a patient when they are subjected to MRI investigation? How should the patient behave in the MRI?
They will be anxious because of the sound noise.
What is the requirement of from the patient to the radiologist? What do they require the patient to be?
Mild sedation, sir.
They should be immobile. They should not move.
Yes.
When they are taking the various cuts, especially in the skull, for
Yes,
any tumor, they don't want the patient to be tossing their head or moving and changing their posture. Okay?
Yes,
So
sir.
immobility is the most important requisite for any patient, whether it is adult or a pediatric patient. The patient should remain still. They should not grossly move. That is the most important thing. And you are talking about giving so much of analgesic like fentanyl or suppository of paracetamol. Is it a painful procedure, MRI?
No, sir.
Oh, then what is the
only will give paracetamol, sir, or otherwise.
Why paracetamol here? What is the requirement for paracetamol in MRI? If there is any procedure or incision planned with MRI control, then we can think of giving any analgesic. What you need is a very still, quiet patient with a secure airway. That is all the requirement for MRI.
Yes, sir.
But the twist in this question or the catch in this question is patient had a recent URI.
Yes, sir.
And how are you going to manage that? So URI, what is the danger? It can track down and become LRI. As long as it remains as URI, it is not going to bother you. After all, there may be some watery secretion from the nostrils, which may track down to the pharynx also occasionally, until it becomes very sticky and color change happens. It becomes mucoid, which indicates there is a secondary bacterial infection. A simple watery discharge from the nostrils is purely viral and it is not going to cause any problem. So you can take measures to dry that up. So how can you dry that watery secretions of URI in a patient before you subject them to make them unconscious for remaining quiet in the MRI?
To decrease secretion, glycopyrrolate.
You can give drying agent like glycopyrrolate. Can you instill something in the nostril to dry up?
Xylometazoline.
Xylometazoline also can dry up the whole thing. It will shrink the blood vessels, and that is where the oozing comes out or the watery discharge comes out. So you can instill xylometazoline, that is Otrivine or Nesivian drops, 1 hour before the procedure, you can give glycopyrrolate, and you said IV line has to be secured with sevoflurane inhalation. Is it ideal for a URI patient? Don't you have other methods of securing IV line without pain?
Ketamine, IM ketamine before.
IM ketamine. You want to go for anesthesia only for securing IV line.
Emla cream.
Cream. The people don't think of that because you are not using that. Babies, it is a wonderful technique to apply Emla cream and secure the IV line without any cause for pain or distraction for the child. So oral midazolam syrup, nasal instillation of Nesivian or your Otrivin, xylometazoline to dry up the secretions. Then secure IV line with a Emla cream application 45 minutes to 1 hour with an occlusive dressing. Through the IV line, give glycopyrrolate 10 to 20 micrograms per kg and wait for the drying effect to come on. Then you can go for IV infusion with the propofol. Why I say only propofol for this baby, even though some of you may not agree that 8 months old baby, it is not safe to give propofol, but now textbooks have started accepting that propofol can be given for babies also. So what is the advantage of giving propofol in this particular case instead of ketamine as you suggest?
Upturn airway reflexes, so
maintain the cerebral blood flow.
Cerebral blood flow or CP angle tumor, will it not cause any raised intracranial pressure?
Raised intracranial pressure. Yes.
So there is a possibility. Ketamine will aggravate that further.
Yes, sir.
Okay. So that also you have to take into consideration, the clinical scenario or the pathology that is present in this patient.
Yes, sir.
So CP angle tumor is also a tumor which is intracranial. So it can cause some amount of raised in intracranial pressure, and ketamine can further aggravate that.
Yes, sir.
So from that angle, it is better to go for propofol region. So Tiva with propofol at the rate of 10 to 20 micrograms per kg per hour will be all that is required, and proper monitoring should be there. Only thing, you must use MRI compatible and MRI safe equipments. Okay, what is the difference between MRI compatible and MRI safe?
MRI is safe, that can be used within the MRI rooms, so like aluminum cylinders and all.
Okay.
Could be
MRI compatible is we use the ECG leads that is compatible with. We have that leads and also we can use it inside the MRI room.
So MRI compatible you cannot use inside the MRI. You said you can use it inside the MRI. The safe also you said you can use it inside the MRI. I think I have told this difference in the class earlier in one of the discussions. This is one of the common questions you will get in the, if you are going to discuss on MRI, this is a very important concept you must have a clear idea. Difference between MRI compatible and MRI safe. MRI compatible machines are compatible with the MRI electromagnetic system or waves, but it may not function properly. For example, if you use an MRI compatible infusion pump, it can be taken into the MRI room. The magnetic waves will not cause any distortion or will not cause the attraction of the metal and all those things. But the functioning of the equipment is not guaranteed when you use a MRI compatible equipment. On the contrary, if you say an equipment is MRI safe equipment, it is safe to use it inside the MRI room, as well as it is functional also is guaranteed. It will function properly. Okay, that is the difference between MRI compatible. MRI compatible, safe to keep it inside the MRI room. That is 50 gauge line. There is a line called 50 gauge GAUSF gauge line, where the magnetic field attracts. There, some of the objects can be attracted by the magnetic effect, and you will have what is called the bullet effect of objects flying and getting attracted towards the magnetic field. Whereas if it is a MRI compatible machine or an equipment, it will not have that problem of getting attracted by the magnetic field. It can be taken as close to the MRI gander as possible. But the functional status of that equipment is not guaranteed if it is MRI compatible. On the contrary, if you say an MRI safe machine, it is not attracted by the magnetic field produced by the MRI, as well as its function is also will be normal. That is the difference between these two. So all the time, whatever equipment you are using, it is preferable to go for MRI safe equipment rather than MRI compatible equipment. If you want the monitor or IV infusion pumps or whatever equipment you are using to function properly, it is always better to choose MRI safe equipment. Okay, that is the difference that you have to remember. So that will be the ideal method of managing this particular case. So I'll just show you. So this is the case scenario that you have. Is it visible?
Yes, sir.
Okay, 8 months old baby, suspected CP angle tumor, needs MRI scan, but patient has an URA. How to manage? This is the question. So again, challenges in this case, as you rightly started, it's a pediatric patient. So all the general problems of pediatric anesthesia likely to have, because it's an 8-month-old baby, likely to have separation anxiety from the mother. And if you allow the child to cry, the chances of ICP raising, cranial pressure raising, is also more. So it is better to give the child some oral sedative drugs like oral midazolam or drugs like phenothiazine group of drugs like Spinergan or Velergan syrup to quieten the baby and then remove the baby when the baby is asleep rather than trying to forcefully separate it from the mother. That is number one. Then there is a possibility of raised ICP due to tumor. That has to be kept in mind. So whatever drugs you want to choose, you have to keep the selection of the drugs with regard to the ICP also. Third is need for immobile patient during scanning. That is the most important requisite for the MRI. Hypothermia is inside the scanner is also another problem which has to be taken care by adequately covering the patient with warm clothing. And noise is the second thing, the next thing. So proper protection from the noise, because the noise may wake up the baby. If your plane of anesthesia is not adequate, the child may wake up and start moving about. So noise pollution should be avoided. And the choice is between whether to go for a full-fledged GA or TIVA. That is the important decision that you have to make. If the airway can be secured, there is no threat to the airway with a normal development of the mandible and tongue, and not likely to have any features like OSA or perirobin or micronanthia, then it is you can go for TIVA safely. But if the airway is in any doubt, then it is better that you go for GA. And in GA, you have to preserve spontaneous ventilation. The airway securing can be preferably done with a laryngeal mask airway rather than going in for endotracheal intubation, because the child has got some amount of URI still there. It is better to go for supraglottic airway device, but you must have adequate experience and you must have been using this quite regularly, and it is not a choice for the newcomer or a beginner. So the drugs that you can think of are propofol, ketamine, as you said, combined with propofol is always safer, or you can use ketamine also if there is no evidence of ICP which has been proved by the preoperative investigation. And nowadays, dexmedetomidine is also considered a very good agent, which can be given as a initial bolus followed by a slow infusion. So these are the three drugs that are preferred for that. And if the URI is quite significant, then there is always a dilemma whether to wait or proceed and do. That has to be decided by the neurosurgery people with regard to the severity of ICP and the possibility of the complications due to raised ICP happening in these patients. Then airway, whether to be secured or not, whether you have to go for a secure airway or whether you can just manage with sedation is the second dilemma that you have to rule out, take a decision on that. Then fasting guidelines have to be taken care whether to go for the liberal or restricted fasting guideline, because the chances of vomiting in case of raised ICP is also there. So that decision also has to be made. And then whether to use MRI compatible versus MRI safe equipment is the next problem that you have to think. So these are the challenges, and difficulty in monitoring these patients is also another challenge in the MRI suit. But the guidelines given in the Association of Anesthetists of Ireland and Great Britain, their guidelines for MRI resonance unit in 2019, that gives one particular statement which is very useful here. The MRI for patients should only be undertaken if the diagnostic benefit outweighs the risk of the patient's life. Okay, that is very, very important. So just for diagnosing or just for the sake of confirming the diagnosis, if the procedure is going to be risky to the life of the patient, it should never be done. So this discussion must involve the multidisciplinary team, particularly for a patient in the ICU also. Okay, so here it is being an infant, because already presenting with a URI. This decision has to be taken after discussion with the neurosurgical team, whether the child really requires the MRI or not. Okay, so that is all this point that you have to keep in mind, and that will be the points that we have to discuss in the exam also, if these cases are discussed in the exam. Okay, right.